Quite a very interesting Thursday. As you might be aware, today being a Thursday, we have an advanced HIV ECHO. And having this session, it is quite important for us to see how best we actually attend to our clients in regard of best practices when it comes to advanced HIV disease. We all know that our goal number 3 in regard of HIV, I mean ART, is to ensure that we have to reduce HIV and non-HIV related illness and death. And achieving epidemic control, the number of deaths in our country have to go down. And that is the reason why we are meeting today, so that we keep on learning these best practices in regard of how we should be managing better our clients. So today, quite a very, very interesting topic. We are having Dr. Chitalu, Chanda as our didactic presenter. We are having also our panel of experts, Dr. Nyuma Mbewe, Dr. Lottie, Hachaambwa, Dr. Suwilanji Sivile, and Dr. Cassidy Classen. So these are our experts for the call today. So I would love as well to acknowledge them if they are on the call. Then the case today is actually, we are having actually an 1 hour session, not beyond that. So we'll have a didactic presentation, then we'll move into questions and answers. And after that, we'll have expert discussion. Then we'll wrap up at the end of expert discussion. So once more, a network, you are welcome to this call. So before we go into the deep presentation of today's session, I would love to acknowledge Dr. Chitalu's presence. Dr. Chitalu Chanda, if you're on the call, kindly greet the network. Dr. Chitalu? Dr. Chitalu, are you on the call? Okay, so I would love also to acknowledge our experts, Dr. Nyuma Mbewe. If you're on the call, kindly greet the network. Dr. Nyuma. Okay. Professor Lottie Hachaambwa, good afternoon. Okay. Dr. Sivile, are you on the call? Dr. Cassidy? Great. So our experts, most likely issues of unmuting. So we will have our presentation from Dr. Chitalu Chanda.
Good afternoon, Doc. Good, okay. Okay, good afternoon, everyone. Welcome. I hope I'm audible enough. Doc, am I clear? Network, am I audible enough? See me some
Sure,
feedback.
you're audible enough.
Oh, okay, good. Thank you so
Yes,
much.
you're audible.
Just wanted. All right, thank you. I appreciate. So I know want us to discuss third line, but I thought that probably what we need to look at is escalating therapy, especially in treatment experienced patients, and focusing on some aspects of third line and some principles thereabout. Okay, we can go to the next slide, please. Yeah, so we will have about 3 objectives that we want to look at. We will need to understand the drivers of high viral load, and then dive into treatment failure, and then we will explore some principles of heavily treatment experienced patients that we might have in our setting. And then we will look at some of the toxicities relating to escalating ART. Okay, we can move on to the next one. So we have a proposition. Doc, you can just go through for us.
Over this proxy that resulted in resistance mutation in the nucleoside component. Which of the following regimen has been shown to be the least effect substitute after 2 years? A, boosted darunava with zidovudine, lamivudine. B, boosted darunava with TDF 3TC, dolutegravir with zidovudine. D, dolutegravir with DTF 3TC. E, none of the regimens above. Network, we've already started receiving some responses. Let's be engaged. Responses are coming, but on the slow, but we are at 36%. We'll end the poll in the next 5 seconds. What is the best question, response among the 5 assertions given to us? Okay, so we are ending the poll here. And this is the result we are having, Dr. Chitalu. 26% believe that D is the correct answer. Over to you. Dr. Chitalu?
Okay, thank you so much for that response. So that sets the tone for our discussion today. I hope people wrote down the various regimens that were there, and I'll discuss it later. So to make us understand, we will need to look at certain terms as regards to a patient with a viral load. So we do know that when somebody has HIV, a proportion of the virus is within the blood, and another portion, much larger portion, is in the sanctuary sites, it's in the lymphoid tissues. So what's in the blood can be measured, and the measurement you're going to get is what you will term as the viral load. So the viral load is basically the number of copies of the virus. This is through measurement of its RNA in a given volume. That is your blood volume. So we do know that you're going to use both, more likely, the paper bottles. So when you get the viral load done by the lab, you want to look at the viral, the amount of copies that's there in the viral, in the blood. So we will start with biological suppression, which is the fourth one. So when we say biological suppression, here we want somebody who has got RNA that's below the detectable limit of the assay. And we do know in our guidelines, we use somebody being suppressed as having a viral load less than 1,000. But between 1,000 and detectable limits, you can get low levels of virus in the blood. So we call that usually low level viremia. So this is the one that you're going to get where patients have a viral load that's detectable, let's say between, let's say 20 copies to 200, that's low level viremia. And that is very important because those are the patients that eventually result in treatment failure. Then we've seen some patients, which is the second one, they are called virological blips. This is a patient who has suppressed viral load, and time and again, they get a detectable viral load that is followed by suppression again. So we'll call that a blip. Some of the patients with viral rebounds, these are patients after suppressing, they get a viral load that is detectable. It's usually around beyond 1,000. And these are what we call a rebound viral load. So if you don't suppress these patients, these are the ones now after some time will go into virological failure. So this is important for us to know because it can be a trigger for you to see, but it will also help you to know what you're dealing with. Next slide. Okay, so when we think about third line, it is very important to know where your patient has come from. And the first line is what will determine what you're going to put your patient on third line. So we do know that some recommended first line regimens will have 3 drugs in the combined, sometimes as a single pill, other times as multiple pills. And in our guidelines, really, we are moving towards the use of TAFED or TTG as first line. But remember, we've come back a long way with some patients having taken Trimune as first line, which I haven't put there, and others taking TLE as first line. So when you're going to review a patient with third line, you really want to see where they've come from in terms of their journey. Because if the patient failed first line, there's a chance they failed your second line. Now they are presenting for you to put them on third line. And some of the resistance that they will have in the first line can actually be archived and then will still be present even in your third line. Okay, next slide. So if you've got a patient with a high viral load who has started treatment in the first line, really you want to evaluate that high viral load. Okay, so a high viral load can be normal in somebody who's just started treatment. That's why you're going to say, has the patient been on treatment or not? Have they defaulted or not? Now, if some patients have high viral load and they're on treatment and they're not suppressing, then they will go into treatment failure. So the major drivers of a high viral load could be poor adherence, could be treatment failure, could be side effects, could be drug interactions, sometimes vaccinations, concurrent infections, and sometimes drug-related factors, especially with poor absorption. So all these can result in a high viral load. So in short, a high viral load is not always equal to treatment failure, but sometimes it can be that high viral load is just as a result of treatment failure. Okay, next slide. So if a patient has a high viral load and you continue to expose them to suboptimal therapy in terms of antiretroviral drugs, or the therapy might be optimal, but the patient or the virus has inherent or intrinsic resistance or acquired resistance, then the viral load will be high and the patient will have a virological failure. So really, there must be ongoing drug pressure that might be suboptimal. with suboptimal adherence, this will be a major driver to resistance. And sometimes the patients will develop resistance because of the type of regimen the patient is on. So if you look at where we've come from first line, some drugs have low barrier to resistance, whilst others have high barrier to resistance, meaning that it takes a bit of time for them to develop resistance, even when there are mutations. So if you look at DTG, it's in the current way we are managing, I'm saying I like it because it's reserving the best for first and not last. So when you think about HIV resistance and treatment failure, really the drug, the virus, and the patient all interact to result in resistance. Okay, next slide. Okay, so it's our second call.
Yeah, thank you. Thank you, Dr. Chitalu. So far, very insightful presentation, and we are learning a lot. So we are going towards our second question, which has been launched. What is major driver treatment failure in first and second line HIV treatment? Is it A, suboptimal adherence, B, side effects, C, drug interactions, D, viral resistance, E, I don't know. So which of the five is the major driver of treatment failure in first and second line? Network, we are remaining with 5 seconds. Let's pour in. Okay, so we are ending the poll now. And Dr. Chitalu, this is the feedback from our network. So 76% have gone for A, while we are having D with 15%, going to C 7%, and B 1%. At least we had no one who had said, I don't know. Over to you, Doc.
Thank you, Doc. I put the last one there. Just, it's always good to give people all the options out there. I would have been happy to see somebody say, I don't know. But I see that maybe they're in that 30% that didn't vote. Okay, interesting poll, interesting poll. And we can move on to the next slide, and then I'll address this poll. So really, when you're thinking about treatment, so when you're thinking about treatment failure, whether first line or second line, really there is a similarity in terms of the etiology of the treatment failure. I know Dr. Sivile is not on the call. He likes to say, well, even if you list them as 1, 2, 3, 4, it still remains to one thing: poor adherence, poor adherence, poor adherence, and poor adherence. So I've done a breakdown here to make us understand that it's not really about pushing the patient to third line, second line, if you haven't addressed the barriers to treatment failure. And whether the patient is on first line, second line, and third line, those barriers will still be there. So the major driver to first line and second line treatment failure is suboptimal therapy. Okay, so suboptimal therapy really could be because of drug factors, could be because of system factors, could be because of viral factors. So when we talk about the patient factors, there are a lot of social determinants here that really can result in poor adherence. Sometimes poor social support, sometimes somebody who is single, somebody who is younger. All these patient factors can result in poor adherence. The other thing could be drug intolerance. So you have the optimal drugs, but the patient can't tolerate. For example, you're on a PI. Then there are specific drug factors like drug interactions, food-drug interactions, the regimen. Then in other systems, you have wrong dosing. I know in pediatric populations, we see a patient who is on a certain dose of Kaletra from the time they are a year old up to 7 years, they're still taking the same dosage, but they've changed their weight. Then there are viral factors here, which you want to understand. Let's say which subtype you have here in terms of the HIV, will have certain mutations, so and how fast the mutations come about. All in all, treatment failure, whether first line or second line, will still remain poor adherence. Next slide. So if you address the major driver before you even push your patients to a third line, really, you're going to deal with adherence. So after EAC, we find a good proportion of our patients attaining viral suppression. And if you use modalities like telephone, facility, community in terms of adherence, you've got a very high yield in terms of resuppression. So this is one of the things that's going to happen to your patient when they go to third line. Really, there'll be an exploration to look at the factors resulting in poor adherence. So when you write that referral, when you send that referral for a third line, really explore the adherence issue. Next. Okay, I think we can move on. Okay, so when you're going to talk about poor adherence, the next thing you want to consider is HIV resistance. I want to mention that for HIV resistance, it really replicates, okay, even without drug pressure at a very high rate. It's got a high mutation rate as well. So it really produces abnormal viral types. So you're going to find in one patient, there are different subspecies or what are called quad species in terms of the HIV. But resistance can also occur in somebody who's on treatment if they have detectable viral load above 1,000. So resistance can occur because of drug exposure and sometimes intrinsically. And if you're going to think about resistance, you really can look for this looking at your genotype. So when you hear, no, collect a genotype after first line, second line, this is to help you put the optimal therapy. The genotype resistance testing that we do is to help us to see if the genes for reverse transcriptase are there. So the NRTI, NNRTIs are there. If you've got INSTI resistance as well, I think there was an echo session which highlighted some patients having resistance to DTG, and this is because you specifically requested for integrase resistance. Then you also want to look at PI resistance that might be there. Again, you do gene sequencing and you see if the genes are accounting for resistance for these particular drugs are there. Remember, these are genes, so they don't really always translate into phenotypic resistance, meaning that the mutations will be there, but the drugs might still be able to work. So if you've got a patient, you address the adherence. The next thing you really want to address and look for is to make sure you collect a blood sample for genotyping to be done. Now, if you're going to collect the genotype, please ensure that one, the patient should be on therapy, because if you collect a genotype, if the patient is not on therapy, they'll have a high viral load, and what you're going to pick will basically be what's called the wild type and will not tell you much information. So ensure that when you collect a genotype, according to the guidelines, the patient should be at least on treatment. Next slide. Okay, so this we've talked about. We can move on. Okay, so now let's go into the matter at hand. If you've got a patient with a high viral load who requires third line treatment failure, really the first step you want to do, we've talked about some of the things you can do in advance, collecting the genotype, collecting the viral load. Again, I'll re-emphasize here, really your first step in the cascade of care is expert advice. Okay, so you really want to consult someone who is an expert in the field so that you put your patient on the optimal therapy, but also the expert to help you to identify some of the things you have missed from your evaluation. It can happen to any one of us. Okay, so you want to look at, you want to get an expert opinion, and they'll guide you in terms of what evaluation you require in your patient, and some of the barriers that your patient might have, and some of the extra tests that your patient might actually require. Okay. Then your next step will be to do an evaluation of the virological failure, confirming it. Then you're going to look at other drivers like CD4s, drive interactions, ART history. So you find the patient who is on third line, you explore when they started the drugs, how they were taking it, when they started it, when they were diagnosed, if they're taking concomitant medications. So you're going to go through the drug history extensively. Then you're going to go through the drug resistance mutations that might be prior or current. So some patients have had a genotype done before, they might have a genotype done now. And this will help you into coming up with the new regimen. Then you also want to look at absorption, okay? It's not just about giving the drugs, you want to ensure that the drugs can actually get into the body. You notice that most of the ART we have require oral administration. Then we also want to address the issue of metabolism. So it's not just about the patient taking in the drugs must be going to the stomach or the intestine and get into the blood and be transported. So we've seen patients who are very ill, who have very low albumin, and they require third line, but you find the albumin is like 10. So even if you put the drugs, not all of it will be able to be transported by the albumin. Okay. Then your next step would be also to screen for comorbid conditions. So you screen for advanced HIV in these patients because they have a high viral load. So you want to screen for TB, you want to screen for hepatitis, cardiac diseases, diabetes. So you're going to do a comprehensive assessment of your patient. So you notice that it's not just rushing to start the patient on the third line. You really want to set your ball rolling in terms of what you require for the third line. Okay, next slide. Okay, so the next poll.
It's Dr. Chitalu, very insightful. So we are on our third poll question. We are going to have them launched. Okay, so this is our third poll question. Which of the following required escalating of ART regimen? Is it A, HIV RNA above 1,000 copies per ml and drug resistant mutation, DRM not identified? Is it B, low level viremia? Is it C, HIV RNA above 1,000 copies per ml and drug resistance mutation detected? Is it D, HIV RNA above 1,000 or on more than 2 occasions? Which of the following is the correct answer? Okay, so Dr. Chitalu, we have very good participation from the network so far. We are going to give some 5 seconds. Then we'll end the poll. We'll end the poll here. Okay, so this is the feedback we are having. Dr. Chitalu, we have 60% believing that C is the correct answer, followed by D at 25%, then A at 14%, with 1% of B. So we need now to get more insight from your end. Dr. Chitalu, over.
Thank you so much for responding to the poll. And it shows that people are getting there. Yeah, so if you look at these different patients that you have, really the first one is, yeah, thank you. So if you look at the different polls that we have here, it's how you're going to deal with the high viral load. So the first one, basically, there is no drug-resistant mutation. This is probably either the patient is not taking ART, they're newly diagnosed. So really, you're going to maintain them on the same therapy and focus on enhanced adherence counseling. If you find someone has got a low level of viremia, you still want to optimize adherence and make sure that they suppress. Okay, then if somebody has now a high viral load and drug resistance mutations are notable, then you really want to ensure that this is a patient you're going to escalate your therapy. So now if you've got a viral load that's more than 1,000 beyond 2 occasions, really you want to look at what are the occasions. Okay, so remember we said some patients who have what are called bleeps. Remember, so you find that the patient had the suppressed viral load, the viral load goes up, comes down. Again, some time later, the viral load goes up and comes down. Again, you want to just optimize therapy in these patients. But if this patient who is D has a viral load that's more than 1,000 and beyond the e-accession period, then you really want to change that therapy to either second line or third line. Okay, next slide. Okay, so now we've discussed some of the supporting things that you need to have done to ensure that you address the adherence, you evaluate your patient, you evaluate for advanced HIV disease, you want to evaluate for genotype, you want to ensure that genotype is done. Really want to say now, what are the principles of escalating your therapy to third line? Okay, so when we say escalating, sometimes it's really not escalating. Sometimes there's recycling of some of the therapies, but it still is escalation in a way that the dosage might be changed, the frequency might be changed. Okay, so let's go through some of the principles of escalation of patients to third line. So first, next slide. So the first thing that we actually do before we change therapy is that we will recycle certain drugs. And there's been a lot of evidence looking at recycling. The first drug we usually recycle in the regimen is lamivudine or emtricitabine. And this is probably because it makes the virus replicate much lesser than the wild type. So we still maintain certain drugs in the third line because they still add benefit despite the resistance being there. And the commonest drug we'll use mostly in first line, second line, and third line will be lamivudine as part of what's called optimized background regimen or BR. So the lamivudine is preferred and is still maintained. And this is because it still gives you the mutations that make the virus not replicate at a much faster rate. Okay, next slide. Next slide, please. Okay, so we, as you can see previously, thank you. It's supposed to be previous. Again, previous. So as you can see, we will go to local evidence. There's the Bison, there's an idea. I just wanted to understand the issue of recycling of ART. As you can see, some of the patients who have been on TLE, like our first line patient that we had initially, some are recycled on TLD, and some are recycled on, has tenofovir now recycled as well. And they added a new component of the darunavir, which was in our guidelines for second line. And some have some therapies being changed to zidovudine, DTG, and 3TC, and others have zidovudine, 3TC, and darunavir. And these are second line before they go to third line. And you will understand that those who had tenofovir being recycled in the second line still did very well, comparatively, even superior to those who had SHT being reintroduced. So really, this gives us evidence plus the Vicent, which shows that if you have a patient who is failing treatment, sometimes in consultation with other experts and evidence, you can see that some drugs like tenofovir will still be recycled. Next slide. Okay, so this is also another example of recycling of therapy. And this is where patients were receiving an optimized background. Then the patients will receive integrase inhibitors or a PI. Again, here, those who received tenofovir and lamivudine as part of the second line still did very well. Okay, next slide. Okay, so if you've got a patient, you started with first line, you mentioned that there are 3 drug regimens, you have your TLE, you have TLD, or whichever first line the patient is on. They might go to second line and they might still fail the first line. So really when patients go on third line, almost 80% of them on second line will have viral suppression being achieved. A small proportion will have failure that is notable on second line, and they will require to go to third line. So what's notable is that when the patient is on second line, they might be, sorry, the poor is showing. So when they go to the second line, they will fail. And remember, some of those on our second line will be on a PI, and they will develop some mutations that may not be on the second line. And what is been noted also is that as you move from your first line to your second line to a PI-based regimen, and sometimes you've recycled the drugs and you brought in the new PI, the patients will have increased pill burden and increased adverse events. Okay, so when you push your patient to your second line, remember a small proportion of them will have treatment failures. You need to monitor closely. And when you move your PI, they'll have resistance to a PI. They can get some resistance to your DTG as part of your second line. And some of these might have a resistance, for example, already to tenofovir and lamivudine. So new resistance can come in. You might require to get a new genotype. So when I was talking about how you approach this patient, you might want to review the genotype when they're on first line, if there is a genotype on second line, and this will help you. Next slide. Okay, so in treatment experienced patients who have received so many drugs, there are newer molecules that you can consider for using besides recycling some of the previous drugs. So we mentioned that you can recycle tenofovir and lamivudine can be recycled as part of third line, and there's some evidence. There are newer drugs on the market that have been shown to be useful. And the first one we'll discuss is called the Hachaambwa. And basically it has multiple sites. It has multiple sites that make it work, or against which it acts against the virus, as you can see in the infographic. So really it will inhibit, okay, the transcription of the virus. It can also inhibit the uncoating of and maturation of the virus. So it's a nucleocapsid inhibitor that is effective against capsid formation and effective against HIV assembly. And it's active against either you're thinking about CCR5 or CXCR4. So really no cross resistance has been noted, and is given really as a 6-monthly injections for treatment in heavily experienced patients. So those of us who are scared, but we're using TLD for first line, we're using TLD for third line, there is an Hachaambwa, and I hope that in the near future, we can have some of it in the country. So this is another option where you're going to add this drug to your already optimized background, sometimes with your recycled drugs as part of your therapy. Next slide. Really, so if you're going to have an Hachaambwa as treatment, you need to know some of the side effects you're going to have is those related to the injection, pain, swelling, erythema, nodules can also form. Other side effects are diarrhea, vomiting, some UTIs, pyrexia. Generally will be notable side effects. Next slide. Then the monoclonal antibodies that you can use as well in those who are failing third line and second line. Sometimes you also might have to add this to an optimized background. So you might have a patient who is taking tenofovir, still maintaining lamivudine, being cycled based on the evidence. And now they might also be on sometimes an INSTI, and you add a monoclonal antibody such as the palizumab. So really what we do know is that it gives you viral reduction that is quite significant in the early days and can be sustained up to a period of 90 weeks. So we noticed that a few resistance types that are noted with palizumab as well. But being an infusion, the side effects are more likely to experience will be hypersensitivity reaction. And sometimes the patient will also experience iris, they will have dizziness, they will have headaches and diarrheas. So this is another option that can be added to your optimized background in terms of treatment. Next slide. Okay. So remember, I've been talking about recycling, and I just want to emphasize on recycling of one of the drugs that might be used in third line. And this is where you're going to use the drugs such as darunavir. So darunavir can be used in first line like DDG, but it's not really a recommendation in our guidelines. It can also be used in second line. And I think this is there in our guidelines now for certain patients. But also darunavir can be used in treatment experienced patients. And this is because it's got a very high barrier to resistance. So if you add darunavir to an optimized background regimen, again, you need to consult with experts in the field because they can advise you on the dosing. Just remember that the higher the dose for darunavir, like any other PI, the higher the incidence of side effects. So really, that darunavir can be used at a different dosage for second line, and it's going to be at a different dosage for third line in a treatment experienced patients. And it might be added to an optimized background. So all these maneuvers you're doing really are guided by your patient's background, your patient's genotype, presence of concomitant diseases. Okay, so the side effects you're going to monitor and look out for in darunavir is that they'll have diarrheas, they'll have nausea, headaches, and sometimes there are changes in the metabolic panels that the patient will have, especially with the lipids, and sometimes there'll be increase in the lipids. So it's a good drug that can be added at a particular dose for those who are requiring third line. Next slide. Okay, so I just want to recap. We've gone through some of the side effects. There are other drugs that we can use for third line. Before we go to the side effects. So there are drugs like miraviroc that we can use. There are drugs like etravirine that we can use as part of your third line. And these also depend on patient exposures. Okay, just move on to the next slide, please. Thank you. Oops. Slide. Okay, so I just wanted to re-emphasize that as your patient move from first line to second line to third line, you will notice that the number of pills the patient is taking starts to increase significantly. So the pill burden goes up. They'll be taking more drugs more often. Okay. Therefore, the side effects also start to increase. The drug interactions are more extensive in your patient. So I've already talked about the INSTIs in terms of resistance, the PIs, especially darunavir in terms of the side effects. Just wanted to recap on two other drugs. Next slide. And we'll start with the darunavir in terms of the side effects, because it might be a drug that you might use for third line, DTG, sorry. Next slide. Okay, so I just wanted us to recap on some of the side effects that can be notable in patients who have dolutegravir. So you're going to use this as part of your third line sometimes, and some patients who have hyperglycemia, headaches, insomnia, sometimes there'll be weight changes, sometimes weight gain, weight loss might be notable. Weight gain, I think we've discussed this before, and it's more common in those who are still taking TAF and more in females, and more occur early, okay? The other drug that I wanted to mention, next slide, is darunavir again. I've mentioned the side effect profile, the next one. So the last drug I wanted to mention is sometimes we have AZT being used as part of third line. And the side effects that you're going to get sometimes is that there's loss of bone mineral density. So some patients, they become osteoporotic, especially older patients. They might be anemias, so look out for that. They might have muscle pains, and they'll have changes in terms of fat, so they'll have lipodystrophy. Okay, next slide. Okay, that should be the end.
Thank you very much, Dr. Chitalu. This presentation was really on point, and a lot of issues have been discovered, and good lessons have been learned. So thank you very much. Any comment from the network? Any question? Kindly unmute. I mean, raise up your hands and unmute as well. No question from the network? Okay, so there is a question from Felix Kasambila. Felix, oh, that is not a question. It was actually a request for the attendance. Dr. Chitalu, maybe before the network comes in, you've mentioned that among the drivers to HIV, to high viral load, we have vaccination and malaria. So you know, we've been talking about a good number of factors, but malaria seems to be quite new, and vaccination leading to high viral loads. May you kindly allow, highlight a little bit on those two factors so that the network can have at least an insight to it. Dr. Chitalu.
Thank you so much. Thank you so much. So yeah, you understand, I've liked the way you've used the words high viral load, not really treatment failure. So these viral loads might be transient, okay? So we can start with malaria. For example, if you have a patient who's got malaria as an example, sometimes they'll be, if they have malaria almost every year, it's been shown to drop the CD4 by at least 40 cells. Okay, so the CD4 drops, and we do know that one of the drivers to controlling HIV actually is not just the ART we give them, it's the CD4. And that's why we want to start your patient early whilst the CD4 is preserved. So malaria kind of just also reduces on your CD4, and that impairs your response to the viral load based on the CD4, and that can cause you to have transient viremias, okay? That goes away. So concurrent infections can also result in that. This is also similar to with what you're going to get in vaccinations, their derangement in terms of your CD4, CD8 responses, and that can also cause transient viremias, not really treatment failures. So it's not something that will be quite long. You just find that there'll be a small rise in terms of your viral load. And this is because of changes in your CD4 that will arise because of either the immune response or sometimes concurrent infections like malaria, which reduces your CD4. For malaria, other things that can be there will be drug interactions that you have. Just a nice thing for you to know. Between the artemisins and your PIs. Okay, so it can affect the PI concentrations, and then that can make it suboptimal. I hope I've answered your question.
That's great, Dr. Chitalu. We have a hand up from Patrick Mung'omba. Please, Patrick, go ahead. Patrick Mung'omba. Patrick, can you unmute? Patrick? So Patrick, you are failing to unmute, okay? So as IT is working on that, we can go to questions which we have in the chat. The first one is from Matthews Ndanda. Okay, Matthews, how long does it to receive results? Okay, how long does it take to receive results from genotype? Then followed by Edwin Musachi with a question of how can we access Darunava? We have been having trouble having it delivered. That is Northwestern Province. Dr. Chitalu, may you kindly respond to these two before Patrick Mwamba comes in?
Okay. So, yeah, I think, let me just look at the first one. How long does it take to receive results for the genotype? The best people to answer that would be someone from the lab. So there are variations in terms of how long it takes to receive that. I think that's the best answer I can give. So there are variations and the people from the lab can help us to address that. Then there is a question on how can we access Darunava? Depends on the indication, first line, second line, or first line.
Dr. Chitalu? Dr. Chitalu? Okay. Anyone from the lab? Dr. Chitalu, are you able to get us?
I can get you. I'm not sure if...
Okay, so you may kindly repeat. We had lost you at a certain point, so you may kindly repeat the second question.
First one,
Dr. Mung'omba, Dr. Chitalu might be facing some network problems. Maybe we might find alternatives.
Yeah. Dr. Chitalu, we are not able to get you. Anyone from the lab to provide a feedback on the question which has been asked in regard of genotype results, the TAT for genotype. Anyone on the call to give a response from the lab? Okay. So Edwin, going to your question on Darunava, that will be escalated and to see with the lab, I mean with a pharmacy. Basically with the stock we are receiving in country, we are not expected to have a shortage or a gap in you receiving Darunava as one of the options basically to be used in second line. So that question has been taken note, and we should ensure that the relevant team work on it so that Northwestern Province receive the commodity timely and accordingly. Dr. Chitalu, are you back? Are you able to get us? Okay, so we have troubles to actually have back Dr. Chitalu. So there is a third question. This is from Dr. Arthur Mumba. Dr. Arthur, you've requested on the current studies I mean, the current resistance patterns observed so far in any local studies done on the first and second line? Is there any pattern on what has been done so far on the resistance which has been observed? Okay, great. So there is another question from Dr. Hamuza. How long must a patient be on treatment before we can consider genotype testing? And Patrick Mwamba, you've written down, you have a concern about the number of people in third line. Can't it play a role again on adherence? Okay, so of course, Patrick, this is a very good question. Adherence is actually key. And the answer to this is that adherence have to be enhanced from the time our client starts medication, because the more you shift from first line to second line, third line, pill burden become high and adherence start becoming affected. So the time we are having this client on first line, the better we have good counseling session with them. In fact, your concern is quite genuine. Okay, so we have Alluvia in stock, and in what cases do we have Alluvia? So this question is not clear. Emmanuel Manda, you may kindly give more insight to the question. Okay, so Kapasha, you've requested that this genotype be done in most labs in Zambia. So actually, these are some of the discussion underway to see how that can be decentralized across the country. And we are very much sure that this is going to be implemented. Of course, you may also take note that when it is centralized, transportation from a faraway district or province, and also looking at the issue of transportation management system, we may be failing at a certain point. So that has already been observed, and the team is actually working on it to see to it that it is decentralized. Okay, so there is, I need now a comment from the network. Dr. Chitalu, if you are back. Dr. Chitalu, are you able to get us? Dr. Chitalu?
Oh, yes, thank you so much. I was struggling to unmute. Yeah, okay. So I think I'm glad that the network has actually posted a picture for us there. I've also sent it in the chat. I hope you can hear me.
Very much clear.
Thank you, Doc. So yeah, there was a question regarding local evidence for some of the resistance mutations that have been reported. So there are two papers. I've put them in the chat. For those that are on the call, you can pick and have a look. One of them is actually showed there. One of the authors was Professor Mlenga. And we have Dr. Samiti, and we have Dr. Pozulu, Dr. Cassidy, who did also other papers looking at the prevalence of the various mutations that we have. So this data actually was generated by most of us who are on this call. So that's to answer the question on the local prevalence in terms of mutations. So now you know that in Zambia, we have patients who have NRTI mutations, who have K65, some have TAMS, some have PI mutations, and now we have also some DTG patients being reported in terms of resistance. Then there was a question, I don't know, I think Doc, you might have answered that one relating to the lab turnaround time and the Darunava. I am very sure you must have answered those two. Thank you.
Yeah, thank you very much, Dr. Chitalu. Yeah, those were answered. There is also another question. Maybe if you would also answer to that. For how long can someone be on treatment for the genotype to be done?
Okay, thank you so much for that wonderful question as to how long somebody. So really, we do recommend that the patient should be on treatment beyond the period of 4 weeks. After 4 weeks of being on therapy, then you can get a genotype done. I'm hoping in the near future, it's a dream that we could have the genotype being done at the beginning of first-line treatment. So right now we would recommend, and the guidelines are that somebody must be on treatment beyond 4 weeks of starting therapy. But obviously in the near future, we'll have patients who are doing the first time you're seeing them, you've got a genotype done. And that will help you to say, let me just start on TLD or TLE or whichever regimen. Thank you.
Yeah, thank you very much, Dr. Chitalu, Chanda. Doc, do you have any last comments to give to the network as we are winding up?
Yes, I just wanted to say that really for me, I was hoping Dr. Hachaambwa would be on the call. He taught me something very interesting. It's not about changing the patient to third line. It's actually about identifying the barriers to why your patient is in third line. So some of our patients are unique. They are all in first line, their own TLD, but they've got individual unique barriers to why they have a high viral load. And you really have to take your time and explore those. It is pointless to put the patient on third line when you haven't addressed their adherence. It would be pointless for you to push the patient to second line when you haven't dealt with their adherence. And some of the patients, the problems they had on first line will still be the same problems they have on the third line. So please, let's look for those barriers and see how we can address them. The next point I wanted to emphasize, I learned also this from Dr. Hachaambwa, is that consult about the patient. Discuss this patient. I've seen most of my senior colleagues, they'll ask me, even if I'm still junior, they'll say, what do you think about this patient? So if you have such a patient who is complex, please discuss. There are two benefits that come out with that. You benefit as a clinician and your patient benefit. Then the last point I want to say is that these patients who have high viral loads who require third line, let's not forget to screen for advanced HIV disease. You don't want a situation where you've pushed the patient to third line, you've got the best drug, and the patient comes to die from TB or crypto, which you could have addressed. So in all these patients, for me, really, it's not about you knowing regimen, it's about your approach and also looking for complications, especially advanced HIV disease. So you want to screen these patients for TB, to screen for crypto, we want to screen for bacterial sepsis, as you are going to optimize the treatment. Thank you so much. I think those are the last few words I had.
Very well summarized, Dr. Chitalu. For those who join us late, I think this summary has actually tell what has been discussed today. And thank you very much, Network. A very exciting topic which we had today. And the message which we are taking back home is adherence, adherence, adherence. Knowing the background of the client, having the genotype done, and also the new drugs which Dr. Chitalu, you've taught us today. I've actually seen the Nakaprava and Ibalizumab. So these are quite new molecule, and the network has actually learned. And you've talked about very interesting issues which we need to know about, factors which can also increase, have high viral loads, and among them, some of the issues which we have neglected, which can actually lead to high viral loads. So team, network, let's get this into best practice and always consult and consult again so that our clients can benefit the best of our care. So as we end the meeting, please let's ensure that we fill in the attendance, register in the chat. That will be very important. Thank you very much, network. We are ending this meeting here. Bye-bye.
Thank you, and have a good day.